her D-dimer was high. We got a CTPA done, which showed acute segmental and subsegmental PE was there. Her oxygen requirement went on increasing. She was escalated to high flow nasal oxygen therapy, which eventually failed, and she was initiated on mechanical ventilation. Her PF ratio worsened less than 100. This was her X-ray. You can see bilateral dense consolidations and GGOs are there. This is her. This was her CD, but I can't play it now. Somehow there is a problem with this. It is not playing. But it showed bilateral extensive GGOs were there because typical of viral pneumonia. So whenever we speak about ARDS, we need to understand the concept of baby lung. In ARDS, there is non-homogeneous sophistication of bilateral both sides, both lungs, which is usually not associated with cardiac failure or fluid overload status. And there is a small part of lung which is amenable for ventilation to happen. Rest all will be flooded and inflamed. So this is a concept of baby lung. And that is how the description of ARDS evolved. And our understanding evolved over time. And last time also Dr. Raghunath has told about this baby lung concept. Will not be spending too much of time there. So next is to understand the definition and classification of ARDS. There are many classifications which were given in 1994 and recently in 2011, Berlin definition has evolved. And now this is the most accepted definition and classification of ARDS. So there has to be bilateral infiltrates on chest radiogram. And if you take a PaO2 by FiO2 ratio, if it is between 300 to 200, it is called acute lung injury, which was not there earlier and it has evolved now. It is acute in onset with bilateral infiltrates. It is acute lung injury. And if the PaO2 FiO2 ratio is less than 200, it is called as ARDS. So ALI can be mild ARDS also. This is depending on the severity of lung injury, it has been classified as mild, moderate, and severe. So mild is PaO2 FiO2 ratio 200 to 300 with the PEEP usually around 5 and there is bilateral specifications. Moderate is PaO2 FiO2 ratio less than 200 with PEEP more than 5 and bilateral opacity is present. Severe ARDS is PaO2 FiO2 ratio less than 100 with PEEP usually more than or equal to 10 and opacity is in more than 3 quadrants. If it is there, then it is called a severe ARDS. So if you all can remember last week, Dr. Raghunath has told you about lower inflection point and upper inflection point. This is a normal lung. The normal lung is, this is how the pressure volume curve looks like, loop looks like. And whenever there is ARDS, there is an opacification or inflamed lung. The PB loop will be shifted to right side. The compliance of the lung will be reduced. So whenever we start ventilating them, we need to give high pressures initially to achieve smaller change in tidal volume. And when a sufficient pressure is achieved, you can see even a small rise in pressures can increase the volume that the lung is taking up. So this point where the change happens is called as lower inflection point. The basic concept of in ARDS is to prevent the alveoli from collapsing, that is to prevent derecruitment, we need to apply high pressures above the identifying the lower inflection point. Usually, typically around 2 centimeters of water is more than the lower inflection point is applied. This is more of a theoretical, it is very hard to detect in a practical situation, but sometimes when you reduce the PEEP, you can appreciate this and you can keep the pressures little high, PEEP pressures little high to ventilate. And when you start ventilating, whenever you increase the pressures little bit the volume taken up by the alveoli or the lungs is higher. And you can see that the compliance of the lung improves. And it is for a particular point of pressure. Beyond that, how much ever you put pressure, the volume achieved won't be that much high. So here there is a risk of volume trauma or barotrauma, or even like if the PP is low, it is atelectasis because of repeated collapsing and opening. Here it will be volume trauma or barotrauma is likely to happen. So we restrict our pressures beyond this point. This is called as upper inflection point. So the concept is to ventilate, identify these 2 points and ventilate between these 2 points. So we have to keep the PEEP high and the tidal volume just enough to be within this upper inflection point. We don't want to cross it. So we give a low tidal volume, high PEEP ventilation. This is the ventilation strategy in ARDS. We need to understand this concept very well before we can understand anything else. So once you know what you have to do, then we need to talk about early management. How do we manage ARDS? This is a guidelines which came in 2019, which summarized the whole concepts of ARDS. So whenever you are initiating ventilation, we have to think of non-invasive ventilation. Without thinking of non-invasive ventilation, as an intensivist, you cannot go into, we cannot jump into invasive ventilation. So can we do non-invasive ventilation in ARDS patients? Yes, early ARDS can be treated with non-invasive ventilation. What are the options? There are 2 options. One is non-invasive ventilation through BiPAP, choosing 2 levels of positive airway pressures. And then other one is non-invasive ventilation through high flow oxygen therapy. So we can use either of them. There are so many advantages and disadvantages with both of them. The advantages of non-invasive ventilation is BiPAP is there will be like we can determine the level of positive pressure that the patient can get. We can know if you have a assured volume, we can know assured volume is going. The patient usually tolerate it better, and we can take it out. We can you need not sedate the patient. Patient can be is allowed to cough. He can talk. He can be put back onto the non-invasive ventilation. But the disadvantage is we should not keep on pulling the patients on this, because if we delay invasive ventilation, sometimes the patient can have worse outcome. So we need to have, we need to keep monitoring these patients. And whenever you put the patient on non-invasive ventilation, you have more work monitoring these patients, because if we don't want to unnecessarily delay intubation, as well as patient should not have hypoxia and arrest. So patient has to be conscious, he has to be cooperative. So all these things has to be kept in mind. Then the other option we have for non-invasive ventilation is high flow nasal oxygen therapy. The advantage of high flow nasal oxygen therapy over BiPAP is that the patient can eat, clear his secretions, and it is more comfortable for the patient. He is not claustrophobic. But the disadvantage is because he has to keep the mouth shut all the time. Otherwise, we won't be able to achieve good amount of positive pressures developed within his respiratory system. So there will be repeated atelectasis and patient can worsen. So what is good? So there are various studies which say NIV is better. Now newer studies are telling HFNO is better. If you go through the IJCCM, recently one article has been published, which says that they have found some statistically significant improvement in patients who have put them on high flow nasal oxygen therapy. But it's a one single center study, so we need to have a multiple larger center studies to authenticate it. So whenever we put the patient on non-invasive ventilation, we have to be vigilant. We should not be unduly prolonging the therapy on non-invasive ventilation, so that the patients will have worse outcome if we later put them onto invasive mechanical ventilation. So we have to keep them monitoring. So initiate invasive mechanical ventilation. We need to sedate, paralyze, and intubate the patient. So initial intubation technique is to like a regular intubation only. Only thing is these patients, if you don't give good amount of volume, or we have to be very careful because they are at risk of hemodynamic compromise and hypoxemia, which can cause sudden bradycardia and arrest in these patients. They'll not give too much of time, so you have to pre-oxygenate them well, prepare them well. If there is a difficult airway, assess it prior before you jump onto intubating them, because by the time you get help, patient would arrest. So there is a thin a margin of error for us in these kind of patients. You have to be well prepared before you jump onto intubating these patients. So once you intubate these patients, the patients can go into hemodynamic compromise. So that can worsen their VQ matching, and then the hypoxemia can worsen. So you need to hydrate them when you're using medications. You have to choose your medications wisely, because if you give propofol and then intubate, there can be worsening of hemodynamics. If you give etomidate also, they can have hypotension and hypoxemia, increase in dead space ventilation, and all these things can happen. So sometimes you need to choose ketamine. So again, the choosing of sedatives and other things has to be discussed, and you have to be vigilant in what you choose. And then once you intubate these patients, once you maintain the hemodynamics, then ensure that you give a tidal volume of 4 to 6. You can start with 6 ml per kg body weight of predicted body weight, and then you assess what is the how much is the initially you give higher PEEP, little higher FiO2, and then go on titrating the FiO2 to achieve a FiO2 or saturation of around 92 to 94. So once you assess for the ARDS, optimize your tidal volume 6 ml per kg body weight, plateau pressure, ensure you use PEEP pressures to get the plateau pressure less than 30. PEEP, generally you keep more than 5 if the patient, if the PO to FiO2 ratio is less than 200. We usually tend to keep 5 to 8. And if the FiO2 PO2 ratio is less than 100, then the PEEP usually keep is around 10. So check for hypercarbia if there is any hypercarbia. And most of the times when we start ventilating, there can be initial hypercarbia. We'll talk about accepting this hypercarbia, that is called as permissive hypercarbia. So once you see that if the PO to FiO2 ratio is less than 200, I told you, you go up on the PEEP to see whether the oxygenation can be improved and the PF ratio can be better maintained. If the PF ratio is not being maintained with the sedation alone, then go on increasing and you can paralyze the patient. Now, there is a trial which came paralyzing initially, early ARDS, not we have to be careful. Don't paralyze a late ARDS and keep them sedated for long, because paralyzing also has problems like neuropathies, myopathies. So we have to be vigilant. A patient can have diaphragmatic weakness, weaning can be difficult. So usually we keep them paralyzed for initial 24 to 48 hours, and especially so if the patient needs uh, prone ventilation. So when all these things are failing, then you have to go for prone ventilation. When do we choose prone ventilation? Can anybody tell? Because I feel I am talking alone. Can anybody be interactive? What is the indication for prone ventilation? Okay, so the prone ventilation indication is if your PEEP requirement is more than 10 and FiO2 requirement is more than 60, that's an indication for we to prone the patient. And we usually prone the patient for how many? What is the duration? If somebody is interactive, we can know. So
Around 16 hours, sir.
yes. Thank you, Nesra. So The prone is usually 18 to 24 hours. You usually prone the patients for 18 to 24 hours, and depending on the feasibility of the center, some centers do not prone at night. So if they reach around 18 hours, then they prone back. Some centers they are okay till 24 hours. So it depends, but it is usually advised for 18 to 24 hours. So these are all the outline, and our target when you're ventilating such patients is we have to maintain a plateau pressure of 30 centimeters of water. And of course, we told about 6 ml per kg of predicted body weight. And we have to keep reassessing these patients all the time. Any ICU patient, not only for these patients, vigilant reassessment and picking up early improves the outcome. So, so our targets are to you can either way. Last time also we discussed the mode is not important. See, that is what I was telling last time. Whether you're doing driving electric car, car with a gear, or automatic car, it doesn't matter as long as you follow the traffic rules. So we need to choose any mode we want, but we should know what to pick up, where to pick up. If we are using pressure control ventilation, if there is a low tidal volume, we need to pick it up early. Tidal volume around 4 to 6, we can start with 6. And if you're able to achieve good CO2 clearance with 6, you can reduce the tidal volume, keeping our targets to less than 28 centimeters plateau pressures. So plateau pressure is 30, rate around 6 to 34 depending on the feasibility. IE ratio we can start with 1:2, and if you are difficult in ventilating, we can go into 1:1 or even reverse ventilation. We don't use reverse ventilation now because it is hardly it is needed, and if you are using there will be hypercapnia, and then carbon dioxide narcosis can happen. So permissive hypercapnia is where we allow the ones initial they take one day to adjust, and we slowly allow the carbon dioxide to build up so that the kidneys start compensating. And if the pH is more than 7.25 with acceptable carbon dioxide, we can just leave, accept it, rather than trying to increase the rate and trying to expedite the carbon dioxide elimination. So that is the target. And our saturation target is around 88 to 92 or 94, you can accept, and PEEP according to the plateau pressures and the oxygenation, we can titrate accordingly. And don't be in a hurry to just keep on changing the ventilator parameters. So physiological rationale of prone ventilation is to whenever we prone the patients, we have to be very careful. How do we need to have at least 4 to 6 people stabilize the neck, hold the tube, secure the lines, good padding of pressure points like the forehead, tip of the nose, bony points, all these things has to be taken care. Move them as a whole. Take care of his cervical spine because you would have sedated, paralyzed the patient. Keep the patient adequately sedated and paralyzed. Please do not paralyze the patient without sedating properly. So if there is a BIS monitor, apply the BIS monitor. If your anesthesia colleagues can give it to you, or you can take it from OT, or if you have yourself BIS monitor, try to maintain between around 60. If that can be aimed, that will be good. So basic concept is whenever because of the gravitation, this thing, there will be enhanced secretion clearance, there will be improved chest wall compliance, it improves the ventilation perfusion matching. There is reduction of ventral lung compression because of the supine ventilation, whatever the lung that has been compressed by the mediastinum weight itself, and the diaphragm movement, compromised movement down is now reversed, and there will be recruitment of those lung regions. This improves the overall VQ matching, and you can see the oxygenation improving for 1 to 2 hours. and there will be reduction of ventilation injured lung injury because your ventilatory parameter requirements come down once you. This definitely improves the oxygenation, but overall, whether it improves the survival is a questionable thing. So coming back to our case, we did try prone ventilation. We failed. We gave ARDS protocol was followed throughout the procedure. We started them on oseltamivir was started, antibiotics, anticoagulation, steroids, and other supportive care was given, but the patient did not improve here. So what is the next? So we did all the ventilatory parameters, non-invasive ventilation, invasive ventilation, and other things. No, the patient is not improving. Patient is a relatively young patient, no other comorbidities except for being hypertensive. So then we have to give them option of ECMO. In 1975, Bartlett et al. Reported the first successful ECMO in neonate with severe respiratory distress. This is Dr. Bartlett. This is the first child, pediatric child who underwent ECMO, and Esperanza became the she actually went along with Dr. Bartlett, and they popularized this ECMO. She is the patient and see how she is there. And Dr. Bartlett is called as the father of modern ECMO. And this was started in 1975, but it was going on slowly in some centers, but it did not pick up pace until 2009 research trial came. So this is a landmark trial which came in 2009. It is a UK-based multi-center randomized control trial. There are 180 adults with severe ARDS less than 7 days with high pressures, oxygen requirement. So they were moved to refer to ECMO centers, and half the patients were managed conservatively on ventilation strategies, and half were managed with ECMO, and they came out with a result which showed that there was significant improvement in patients who are treated with ECMO. So that is how the ECMO picked up from 2009. So ECMO, the basic concept is you take away, this is a VV ECMO. VV ECMO is veno-venous ECMO, where the heart is normal in such patients, but you have problem with oxygenation and elimination of carbon dioxide. So heart functions as it is. So you take out deoxygenated blood from the vein, major vein, you oxygenate it, take out carbon dioxide, pump it through the another vein. This is called as VV ECMO. It is a two cannulation approach. You can use a single cannula also. So this is from the femoral vein. Your drainage is from femoral vein and returning it through internal jugular vein. Here you are draining it through femoral vein and returning it through femoral vein. This is femoral. This is femorojugular. So we use VA ECMO if the heart is failed or heart and lungs are failed. You need both the support. If only lung is a problem and heart is okay, then we can go for veno-venous ECMO. So in ARDS patients, if the heart is good, then we have to use veno-venous ECMO. So here you can see this is the jugular catheter. I'm sorry, we can't, the femoral venous catheter is low down. You can't see it here. And this is the IJV, this is the tracheal tube. So this was the lung, how it was. And this is our ECMO patient. We connected them, this patient on ECMO with sedation
Mr.
paralysis.
Madhav, can you put in slideshow actually? So it will
Oh,
be.
sorry. Sorry, from the, like, I forgot about it. I'm
Okay, so
looking
X-ray,
within.
at least X-ray they can.
Yeah. So this X-ray, can you appreciate? So this is the patient, and you can see. So whenever the patient is on ECMO, what is your ventilatory strategy? Our ventilation strategy is to ventilate them with minimal tidal volume and minimal harm. So we usually keep a pressure control mode of pressure control of 10, PEEP of 10 and respiratory rate of 10. And even if the patient breathes spontaneously, we allow them to breathe. We don't sedate them. Initially, we sedate them. And once the patient gets used to it, then we reduce the sedation. We don't paralyze the patient. Usually patient tolerates it by that time, because patient would have already undergone sedation, paralysis, prone ventilation, other things. So their tracheal tube tolerance will be much better. And you can see tracheostomy is also being done on this patient. So the ventilatory strategy is usually rule of 10, pressure control of 10, PEEP of 10, and respiratory rate of 10. So the course we had in this, on day 7, patient, we did a tracheostomy. Whenever we have to do a surgical procedure, these patients, ECMO patients, will be anticoagulated with heparin. Our target ACT will be around 180 to 200. We'll be using continuous infusion of heparin. So we need to stop heparin, ensure the ACT is around 150, and do a quick surgical tracheostomy. Day 10 patient has the shock. We thought it is because of sepsis. Antibiotics was escalated. We changed the CVC, and then we noticed the patient had, because we put a left CVC, patient had pneumothorax, so we had to put an ICD. So then we continued ECMO support for these patients. Day 12, we saw that heparin requirement is going up to maintain ACT. ACT we could hardly maintain 150, but the heparin requirement is going 500 to 600,000 units per hour. Then we suspected heparin resistant. We gave a little bit of FFP. FFP will have antithrombin, so it will improve the efficacy of heparin. But it improved then, but again quickly it worsened. Then we noticed that the platelet also is going down, probably because of heparin-induced thrombocytopenia. So we stopped heparin and started fondaparin next 2.5 mg BD. And day 13, patient had made significant improvement. Again, there was worsening. Patient needed high oxygenation, high flows to maintain CO2 elimination. Then X-ray showed right lung patch. Uh, it was like 2 3 days it was persisting. We did a bronchoscopy. Post-ball patient had hypoxemia. Hypoxic seizures was there. We treated it with Levipil. During the course, patient had multiple PRBC transfusions because of anemia. And slowly patient made gradual recovery. Day 17, patient improved. Sweetgrass Pro we could gradually reduce, and we could wean the patient ECMO and off ECMO, and we decannulated the patient. And finally, with tracheostomy, patient could be maintaining. We could wean them off, wean off ventilator also. And this presentation outlines the how ARDS can present, how H1N1 ARDS is presented in this patient, and what all aspects of ARDS we can do. So now this is open for discussions. Anybody has any questions, please raise it up. Anybody there? Any questions, please?
Dr. Shailaja wanted to ask actually one question.
No
The
questions. No
PEEP
questions.
criteria, what is the prone ventilation? When you think of prone ventilation,
Anybody to answer?
No, sir, I got the
Sir
answer.
is asking.
Oh,
Okay.
I got the answer, sir.
okay.
Yeah, please tell us.
Hello.
Yes, madam. Please, madam. Please.
Sir, PaO2, FiO2 less than 150 with
Hmm.
PEEP of more than 10 or more than 10 and FiO2 more than 60%.
Anything you want to add, Dr. Mahadev?
Yeah, usually we follow if the patient requires more than 10 PEEP and FiO2 more than 60 to maintain a saturation of 92, then we prone the patient.
Dr.
Sir,
Shiva?
I have one question.
Yeah.
Yes.
I would like to know that our target oxygenation, what should we choose? Lower PEEP, higher FiO2, or higher PEEP, lower FiO2? Here is the confusion because what I get from you, it's a mixed concept.
We need
I
to,
choose lower PEEP or higher FiO2, or I should choose higher PEEP as you are saying, 12, 10, and lower FiO2 along with it.
no. Depending on your PaO to FiO2 ratio, initially you can start with higher FiO2
Mm-hmm.
and start coming down on the PEEP, on the FiO2. So once you start coming down on the FiO2, you will start the saturation coming around 94 to 92. At
Mm-hmm.
that time, if the PEEP is low and the FiO2 is high, go on slowly rising the FiO2 so that
Okay.
go on slowly rising the PEEP so that you bring the PEEP around 10 and start coming down on the FiO2. So we would prefer a PEEP of 10 and lower FiO2. And if the FiO2 comes less than 40, then start coming down on the PEEP.
All right. Thank you, sir.
Did you get it?
Yes, I got it.
Yeah. So our target is to have a higher PEEP and FiO2, acceptable FiO2. And our
And
basic idea is to improve PaO to FiO2 ratio.
And sir, what about target plateau pressure and target driving pressure in the
Target
ventilator
plateau pressure
settings?
is, we accept a plateau pressure of 28 to 30. So if feasible,
28 to 30. Okay.
try to get it down less than 28. If not, you accept plateau pressures of around 30. If you're not able to achieve this target, at least achieve a driving pressure of 16 to 18. Driving pressure is plateau minus PEEP. So sometimes patient may have bronchospasm or something like that. So, or is lung compliance, he may be obese. So his plateau pressures may be little up. So you accept plateau pressures higher, but try to get the driving pressures around 16 to 18.
Okay. Thank you.
Sir, if the plateau pressure is more than 30, then what is the next step?
More than 30, then try to reduce the tidal volume. Try to reduce the tidal volume, accept some hypercapnia. Don't chase the carbon dioxide. Accept the tidal volume, lower tidal volume. If the pH is acceptable, more than 7.25, leave it like that. So over time, kidneys will compensate and the pH will improve. If the pH is lower than 7.25, then try to eliminate carbon dioxide, otherwise accept it. And try look for other causes of acidosis. If there is an associated metabolic acidosis, try to correct it. If there is a shock, lactates are high, give some vasopressor support. Take care of if there is any other source of sepsis. The antibiotics are covered, fluids are adequate. Do a POCUS. So all other things has to be taken care of. Just because pH is 7.25, don't have to like hyperventilate the patient.
Okay, no, thank you. So one more question. From the initial presentation, are there any hints to identify ARDS versus other causes? And is the final conclusion based on radiological findings?
Definitely, it is a history. History will give us the clue whether it's primary or secondary ARDS. There are some clinical situations which can cause secondary ARDS like trauma, pancreatitis. So we have to be vigilant on those things, on those areas. And sudden multiple transfusions can cause trolley. So basically, it is a radiological and clinical diagnosis. So bilateral homogeneous opacities, if you see, so it is ARDS. If you see one side dense consolidation, that may be a severe pneumonia or community acquired pneumonia or aspiration patch. There, our classical ARDS protocols like prone ventilation and other things may not help that much. But classical bilateral consolidation, the definition, Berlin definition is very clear. You have to have bilateral patches, hypoxemia, acute onset, and then in the absence of cardiac failure or fluid overload. So then that is ARDS. So the criteria are very clear. We don't have much of a problem in identifying these patients.
So when
So, sir,
we
we have to follow latest Berlin criteria or ARDS new global definition, because ARDS new global definition was from last
Yeah,
year,
ARDS new global
2024.
definition is mainly to include patients on non-invasive ventilation. See, there are patients who are ARDS, mild or moderate, who are being
Mhm.
managed on non-invasive ventilation, especially high flow nasal oxygen. So, new global definition is to include all these things. So, it is both inclusion as well as
Mhm.
categorization. So, it doesn't tell you to take away Berlin's definition. And new global criterion is not fully accepted all this thing. It is mainly in resource limited settings where you're using non-invasive ventilation, where you're not using ABGs, you're depending on saturation monitoring. So to include all those
Mhm.
patients, they have come out with that.
Mhm. Okay.
Sir, what criteria do you follow to switch from non-invasive to invasive ventilation? Or how much time do you allow trial?
See, like when we know it is a bilateral opacities are there and the oxygen requirement is going up. If the patient's oxygen requirement is going up and the patient's work of breathing is going up despite on these things. So you usually wait for a 6 to 12 hours time. In ARDS patients, once the patient goes into ARDS, it is a disease of weeks. It is not like patient is likely to recover in a day and then walk out. So if the patient is work of breathing is going up, then why wait on such patients? You can electively intubate, ventilate, counsel the patients for intubation and go ahead. Especially only situation where we would like to wait is post transfusion. You have given trauma patient, you have given multiple transfusions and then there are some patches. There you can wait for some time, and if the patient settles on non-invasive ventilation, either NIV or HFNO, we can wait if the patient is conscious, cooperative. Otherwise, we intubate these patients. Especially a trial of 68 hours, and if the patient is not improving, his work of breathing is not improving, is still tachypneic, struggling, he desaturates with little disconnection, intubate these patients.
Okay, sir, thank you. So when you initiate BiPAP, what are the initial settings, pressure settings we choose, and how do we titrate?
It is also similar to invasive mechanical ventilation only. You can start with higher EPAP, higher FiO2, and target a tidal volume of around 4 to 6 depending on the pressures you choose. Look at the tidal volume that the patient is generating, and then go on reducing the FiO2 till you get an acceptable saturation of around 94. If the patient is not, you reduce FiO2, and if the patient needing high FiO2 to maintain his saturation, then slowly go up on the EPAP as well as IPAP, so that both the ratio is maintained to maintain a adequate tidal volume. So wherever you get a good oxygenation, there you stop, and then slowly start tapering the FiO2 later on. Don't be in a hurry to taper off ventilator assistance in ARDS patients. As I told you, this is a slow recovery disease. So you have to be little vigilant and little slower. If you hurry it up, then patient will de-recruit. Again, you'll have to go up on the pressures and other things. Again, you need to take a 2 steps back. If you hurry up for 1 step, you have to, sometimes you'll have to go back 2 steps and come slowly. So better to go slow, especially weaning, go slow and titrate it. Anything else? Any
Yes,
questions?
sir. I have one more query.
Yeah.
Regarding prone position, when we should decide to be do it, like
As I
after
told
how
you,
long?
conventional mechanical ventilation you started, and if
Mm-hmm.
you're not able to come down FiO2 less than 60, and your PEEP requirement is more than 10, that is the time you have to prone ventilate the patient.
Okay.
Hello,
Even
sir. Uh, During prone ventilation, how do we assess fluid responsiveness or monitor hemodynamics during prone
you have an
ventilation?
arterial, if you have an arterial tracing, if you sedate and paralyze the patient, if you notice there is a pulse pressure variation on the tracing, then you can give a titrated doses of fluid and C. Classically, you can't put a IVC measurement and other things will not be possible. Or give a small dose fluid challenge and see how's the response, hemodynamics, urine output, lactates, and if the patient is showing some improvement, then you can give slight. In ARDS patients, unless the hemodynamics are compromised, we are not in a hurry to hydrate the patient too much. So we give guided resuscitation. Now the concept is guided resuscitation. Don't give too much fluid. Keep the lungs little drier side only. So sometimes after the initial resuscitation is over, we de-resuscitate the patient to keep the lungs dry. That will help the lungs to recover faster than giving the fluid. We are giving the fluid only to maintain hemodynamics if there is a shock or something like that, or ongoing loss is there, then we need to rush in fluid. Otherwise, just give a small challenges and see if the things are okay. If the hemodynamics are holding on with minimal inotropes and all, then there is no need to rush for resuscitating those patients. Have a
Okay.
controlled resuscitation policy.
Okay, sir. Thank you.
So if there are no questions, can we wind this up?
Yeah, thank you, Dr. Mahadev. It was a nice discussion, interactive discussion. I think students can come up with the case and present themselves so they can answer their queries. I know it may be look so simple question, but it is a very important to understand the concept and clear at each level. When you intubate, how much you put tidal volume, how you reduce the tidal volume, how you increase the PEEP, how you reduce
So this
FiO2.
is, see, we are all fine-tuning our clinical skills. This is not a, so most of the videos are there. You can go through them and like a theory class. So whatever we are doing is not a theory class. It is more of a practical oriented approach and discussion-based learning. And we are all we are not doing MBBS schooling. So we have to come out with whatever questions you have and discuss it out, and then like find a solution for it. So it's more of a practical based approach, and so you need to actively participate. I request
Yeah.
that they happen.
And evening, this session was basically with a request from some students we have put actually. So I think even record version will be there, but try to attend the live session and understand the concept clearly. So I thank Dr. Mahadev and all the participants,
Thank you.
and we will close this. Thank you. Thank you.
Yes.